Good morning and good afternoon. Thank you so much for taking the time to join us today. I am absolutely thrilled to have Dr. Jeff Salvon-Harman join us for our collaborative conversations today. As a personal note, he has been a mentor of mine and a colleague of mine for the last several years, working with me both through the SLS collaborative as well as through some IHI work. So I'm excited to have him share his knowledge and some of his thoughts that have really made me think differently about the differences between how docs and nurses think about patient safety. I've been doing this for 30 years, but have never put that frame on it. As an introduction, he did his family medicine residency in Roanoke, Virginia, and medical school at Tufts University's School of Medicine in Boston. He has worked with the U.S. Public Service and spent 20 years in the Coast Guard. He's a clinician and a leader, has been the patient safety officer at IHI and a chief quality officer at Presbyterian. And with that, Dr. Salvon-Harman, I turn it over to you.
Terrific. Thank you so much, Jeanne. Good morning. Good afternoon, everybody. It is wonderful to be with you and so happy to have this opportunity, as Jeanne was saying, to maybe reframe what we've observed, but maybe haven't put into concrete terms that influences the reporting and the learning from risks and safety events, due in large part to professional difference. And from that, then we'll talk about what we do with that information. We're aware of that, and we framed it and scoped it and talk about some potential solutions. So with that, we will launch into two conversations, one word, safety. Now, first, I'd like to get started with a simple poll to understand who's with us today. Allison's going to bring up the poll. If you would please indicate your professional role. Give me just a moment. That'll help me to calibrate to this audience. Thanks. Okay, so a lot of nurses and a little bit of physician representation. Excellent. Okay. Now, secondly, to get to know you a little bit better, check all that apply in terms of your level of expertise in quality and safety. Are you a novice or a beginner? Are you experienced and mid-career? Are you seasoned and or expert? And do you retain a certification in either healthcare quality or patient safety? Okay, a lot of experience in intermediates with CPH. It's wonderful. So let's start with a safety story, because that's a best practice in patient safety in healthcare and in most industries. Starting with different perspectives on the same event. Now, looking at the picture on the right side of the screen, it's pretty evident that something's not right. Boats typically are not trailered on top of the pickup truck. And as you start to look more closely, you can see that there is what looks like a light post, a traffic signal in front of the truck. And the truck's front fender starts to look a little bit deformed. The boat trailer looks to have collapsed on the neck of the trailer and connecting it to the pickup truck. And the boat is, as you can very plainly see, sitting right up on top of the pickup truck. So like any adverse event, we start coming up with ideas and asking ourselves questions. How did this happen? What were the circumstances? Not at all unusual outside of safety professionals to be asking, who did this? Whose fault is this? Because that's something we see in our social media and public media, our legal system. But let's think about the reporting of an event like this and the different perspectives, and thinking about whose perspective matters most, who is right, or who is at least most right. And that's where we start to see some challenges present themselves in the real world, but particularly in healthcare. We think of this as a metaphor for an adverse event in healthcare. Whose perspective in healthcare do we think of as being most accurate, most important for reporting? And do we tend to get multiple reports, or do we get single reports when something has gone awry? Now, in this scenario, we can think about different perspectives, such as the driver's perspective. They were at control, the front seat passenger, the rear seat passenger. So people who weren't controlling the vehicle, but were observing what was going on. Maybe they were not. A witness on the sidewalk who maybe saw this happen, but of course they might not be looking until they hear a loud crash, and then they look and they start piecing it together. The driver of an oncoming vehicle, the driver of a following vehicle, all of those are different perspectives. And And see that in healthcare as well, in terms of people who are directly involved in events, people who are peripherally involved, people who are simply witnesses, not involved at all, witnesses from different perspectives. So, whose perspective is most valid? Would you please answer in the poll which one, only choose one of the perspectives is most valid in the case of this auto accident? Okay, so the majority say the driver, and then secondarily, witness on the sidewalk and driver of a following vehicle, but not the oncoming vehicle. Interesting. But the focus on the driver, the person in control of the vehicle, or presumably in control. Thank you. So let's think about why we select the person whose perspective is most valid. Why is it the driver for the majority of us? Is it because they're in control? Is it our presumption that they are in control? Is it that we expect that they'll be paying attention, whereas passengers in the vehicle are not paying attention? Similarly, witnesses outside may not be paying attention until something goes awry, whereas the driver should see the evolution of what's going awry. Maybe we think the driver is likely to be the most experienced, but what if they're not? What if this is a new driver and it's a parent in the passenger seat? But what if this is an aging driver who's developing some sensory limitations? How much do we think that experience matters relative to that direct involvement? Is a seasoned driver in the passenger seat maybe a better reporter and or describer of the event than a junior driver? And then we might also ask, how important is observation relative to direct involvement? Is the observation of a novice driver or the observation of an experienced driver more important than the perspective of the person directly involved? We start to get into the valuation of these perspectives, and we start to attach presumed significance to these based on expertise, years of experience, level of involvement, level of observation, level of vigilance or attention given to the situation. But we know oftentimes that everything seems to be just fine until it's not. So things, and then we start trying to piece in our mind together what happened when an event occurs. And so then as we start reporting, we think about who's reporting and what was their role in the event if they're reporting it. So that sets the tone for what we're going to dive into today. A quick look at our agenda is that we're going to look at professional and cultural factors that drive reporting behavior. We're also then going to look at system workflow and organizational barriers that affect physicians and nurses differently. And then we're going to move towards solutioning so that you come away with some ideas of what might be done about these issues. So finding common ground for patient safety. And then finally, because many times solutions are presented, but very little information is given about how to actually implement those solutions effectively. And we know there's this growing body of information in the evidence base about ineffectiveness of quality improvement and safety improvements and why that is, why they don't stick. So I want to share with you some ideas that will help to make things stick and help you to be successful in implementing change. So let's start with what the evidence base tells us about why healthcare professionals withhold voice. And I think this is really important framing using the term withholding voice, right? We talk about speaking up and not speaking up. We talk about silence or being quiet. But honestly, when we see something and we don't report it, it's most often because we make a conscious choice to not report. That we actively withhold our voice for a number of reasons, and they're listed here. So this is an act of omission or an act of commission. We are committing the act of not reporting, as opposed to an act of omission. We simply not report, because the omission could be distraction, could be time prioritization. But the act of commission is the act of withholding of, in this case, our voice or a service. And so the reason why that may happen start with the motivation to speak up. Do we perceive that the risk for our patients? Do we sense it as real time and at a high enough threshold if we have a threshold to report? All of us have a library of experiences in our minds. And so we're comparing to that library of experience. That experience includes our education, but it also includes the various professional experiences throughout our career. And so that library helps define what our threshold for reporting is. Might have a very low threshold where we report everything we can. We might have a very high threshold because it doesn't feel like it's worthwhile to report everything. And that gets into some of these other reasons for withholding voice. So next is contextual factors. So thinking about the environment in which we're operating as the context, is there hospital administrative support for reported events and for improving system designed for safety? Is there an interdisciplinary policy making process where we know that if we fix something, we don't just fix it in our backyard, but that we're fixing it for the entire neighborhood, if not the city? Teamwork and relationships with other team members can have a significant impact on whether we report or not. Is it a normalized behavior across our work team, or is it an exceptional behavior? So it requires overcoming more inertia in order to use our voice and not withhold it. And certainly the attitude of leaders and supervisors around the reporting. Is it just another administrative chore then for them as a result of reporting? Or do they perceive the seriousness of it? And do they perceive that the system supports taking action to do something about it? We can look at the individual factors, meaning our own factors as the person involved or observing. What's our level of job satisfaction? Are we engaged? Do we sense belonging? And so we want to be a part of making the system better. And reporting is one of the ways to do that. What's our level of responsibility toward patients? Do we perceive ownership and connection, or are we disembodied and we pop in from time to time? And we see that across different roles and in the time intensity, the immersion in the patient's healing journey, as well as the immersion in who the patient is. What's our responsibility as professionals, and how do our professions define that? That's partly context, but how we understand and perceive that is the individual factor. Do we have confidence based on experience that using our voice will make a difference? Or does it feel like it's an exercise in futility? And do we have the communication skills to be able to report this in a way that's meaningful and will garner attention? And then, of course, what's our educational or professional background? Because that influences how we perceive the risk and perceive our threshold for reporting. Next, we have perceived efficacy of speaking up. This is probably really the second most important to the motivation. If we perceive from past experience and hearing from others that it goes nowhere, it goes into a black hole, that no action is ever taken, there's no feedback loops, we never hear whether it made a difference, lack of impact from that reporting, then we're much less inclined to do. And similarly, we have any kind of personal control in those system changes that are made. What if we report something and it results in a change to the system? It makes our work more difficult and makes our job satisfaction lower. Or are we involved in that process of defining what a new system or workflow should look like? And then lastly, the perceived safety of speaking up, right? The psychological safety and the trust. Do we feel like everybody's going to turn on us if we report something? Do we feel like one important individual may turn on us? Do we feel like everybody's got each other's back and we can trust in what others report, that it's about the event, that it's not personal vendettas? Similarly, that we can report and be trusted in the same way. So those are really the key drivers around withholding voice. And as you can tell, it's all about the people, right? It's not about the system so much. Mostly it's about how the potential reporter perceives the system and its responsiveness, as well as perceiving the trust and psychological safety among peers and colleagues. So we're going to dive a little bit deeper now that we know what the evidence base tells us. This is going to be a little more based on experience and some anecdote, but also tied into the evidence base. So first, looking at the human side of safety reporting, or professional and cultural factors. We know that role identity and clinical responsibility are both trained and practiced differently between physicians and nurses. And I'm going to focus really on those two professions primarily for the rest of the presentation. So I can speak directly about physician training. Granted, it was 30 years ago. Some things have changed a little bit. Many are still the same. There's a focus on autonomy, that in physician training, you're the terminal professional, meaning buck stops with you. You're the one expected to render a diagnosis, especially if you're a specialist or a subspecialist. There's not somebody else to refer to beyond you. It's got to be you. There's a lot of leadership that is inculcated, but not necessarily taught as leadership when it comes to physician training. And as I mentioned, this concept of terminal expertise, of having to be the final decision maker, the final diagnostician, as well as a treatment definer or planner. Nurse training, I am familiar with from both my spouse, who's a nurse, and from many nurses that I've worked with and talked to have very frank and transparent conversations. Nurse training focuses on independence. I use that word as opposed to autonomy because that independence comes with the idea of really owning the patient relationship and being independent to manage that relationship, but not necessarily having all of the decision-making authority that we connect with autonomy. So there's independence. And then there's this kind of duality of subordination that nurses act on orders from clinicians, physicians primarily, but more and more also nurse practitioners, physician assistants as clinicians with physicians. But nurses are not able to write treatment orders. They have to follow orders. So it creates a subordinate role for nurses in most cases. And then what really struck me the most, hearing this from my wife, hearing this from other nurses, is this concept of nursing being the last line of safety defense for patients. Nurses are at the bedside with patients more than anybody else. Nurses know the care plan, they execute the care plan. So they're the one at the front line, so to speak. They're the one most well positioned to detect or sense that something's not right and try to keep it from happening. But we know that nurses are fallible, just like all humans, physicians are fallible. And that last line of safety defense puts a lot of pressure on the nurses, but also really affects the threshold for reporting. And we'll talk a little bit about that next. So as we think about this interpretation of reportable events, physicians typically perceive that there's a very high seriousness reporting threshold, meaning let the little stuff go. It's not important, right? Small potatoes, hand hygiene infraction, a minor peripheral sterile field break that's not close to the window that we're operating in, kind of thing. Context probably plays a role in the OR. It's probably much stricter about sterile field versus bedside procedures. But in general, physicians tend to not look at the entire broad spectrum of safety. They tend to be focused on balancing whatever this new identified risk is for safety with all of the other risks for the patient. I'll give you an example. When I was a Presbyterian Healthcare as Chief Patient Safety Officer, talking with intensive care physicians, intensivists, about trying to reduce central line associated bloodstream infections. And this was like 2019, 2020 timeframe. So we're not talking 30 years ago in this case. There was still a pervasive sentiment that eclampsia is not the worst thing that could happen to this patient. They're in the unit fighting for their life. Hospital-associated infections, conditions are simply the cost of doing business. They come with the territory. And we know that flies in the face of all this evidence base from the last 20 years that, in fact, eclampsias are nearly 100% preventable, far more preventable than what I was hearing from this physician leader of the intensivist group. So that's how physicians see things oftentimes, is they're weighing a risk against the bigger picture of what's going on with the patient and the patient's other risks. And then I contrast that with the nursing perception, which is much more all-encompassing, right? It's much more aligned with traditional views of safety. That safety has many different contributing factors across different levels of individual, of team, of environment, of supervision, of organization. The layers that you find in the Swiss cheese model from James Reason, that you find in the human factors analysis models used by DoD, that you find in the systems engineering to improve patient safety, or SEAPS model out of University of Wisconsin. This low threshold and all encompassing. So looking at all threats and risks and acknowledging the movement in the last 20 years of safety science to addressing the little things because they prevent the big things from happening instead of skipping the little things and waiting for the big things. And so that low threshold includes things like behavior, communication, teamwork, team coordination. And that's where we see the friction really arise between physicians and nurses with safety reporting. Because oftentimes what we'll see is nursing will report a physician behavior in the adverse event reporting system, the safety event reporting system. And in doing so, the physicians perceive that as a personal attack rather than perceiving that as yet another potential contributing factor to safety for a patient or on a unit. So that becomes truly problematic. And I just want to do a technology check because I noticed a little bit of flicker on, and my image on screen is now blurred.
Yeah,
Jean or anybody else, am I coming through clear?
you are blurred.
I am blurred. All right, let me try toggling my camera. I am still blurred. There's anything else I can do?
While
Okay.
he's doing that, and oh, there he is. May I ask the group question and have them respond in the chat?
Yes, by all means.
All right. So think about, and please do respond. We want to interact with you. It's called collaborative conversations for a reason. So if you could type in the chat or unmute yourself, either doesn't make any difference to me. But think of a hypothetical time when either you or someone you know didn't report an event. And what was it that held you back? What was that decision that you made? And I'm going to start by putting mine in the chat because it was just a couple of weeks ago.
Thank you, Jean. And as always, a part of what I love about the professional relationship with Jean is her humility, her transparency, her candor. Here's a seasoned physician who's still talking very real time about things we would think as experts we wouldn't be prone to, and yet we're human too, and so we experience them as well. I just think that's so valuable. And Jean, I'm grateful. For those who know Safety Learning System, gratitude is a key component, and I really hold gratitude in my heart for your candor, your transparency, your courage, and your humility. I see we've got other folks chatting in, so that's excellent. Thank you. I'll continue on as you're chatting in. I was talking about this psychological safety component, but the hierarchy figures into that too. As safety reporting systems become the default communication channel to leadership in psychologically unsafe environments, we find that's even more significant when hierarchies are rigid, when there's that very strong physician is God, physician is king, physician is infallible, ivory tower, pedestal, you name it, and everybody else subordinates. We've seen so many examples in other industries where the authority gradients are flattened, where pilots and flight crew are on a first name basis, for example. In the military, even during military operations, first names may be used rather than ranks as a way of deflating those authority gradients. But where we see these rigid hierarchies and these strong authority gradients, oftentimes those who are in the subordinating roles feel like they don't have the opportunity to speak up, right? They withhold voice because they don't perceive that there will be effectiveness, or they may perceive even personal risk in doing so. And so they'll use these sort of neutral channels to try to communicate a concern, because ultimately they may still be looking out for what's best for patients and feel the need to communicate that. And so we talked about that as the weaponization of safety reporting systems. And I should say, when I say we in this case, I'm saying physicians talk about that as the weaponization of safety reporting systems, because they feel like those reports about conduct and behavior are not about what we might consider workflow or structural safety risks, the personal attack, and should be managed through HR or through the medical staff, but shouldn't be in the safety event reporting system. And then finally, in this category, we have the fear of blame, liability, and reputation. And I think that's very real for physicians and nurses. Nobody wants to be sued. Nobody wants to have to invoke their malpractice insurance and see their rates go up. But also nobody wants to go through that process of being publicly questioned, maybe flogged, maybe publicly contradicted, and maybe found to be in the wrong, so to speak, to face a penalty for having not done the quote unquote right thing. But we understand the complexity of medicine. But in those moments, that fear of blame, liability, or loss of reputation can be visceral and can be in those reptilian brain sections where we just reflexively go there. It's not a conscious decision. And so got to increase awareness about that, as well as try to design systems around knowing that's part of the problem and overcoming it.
While you're moving to the next slide, and before you ask that poll, I've got a clarifying question for you. My understanding of the research is that nurses actually perceive more movement in response to their
And we
report.
will get to that shortly.
And
You're
you'll get to
absolutely
that.
right.
Oh, okay.
Yeah. And I'll speak not only the what of that, but some of the why behind that.
Perfect.
So thank you. All right. Poll question quickly. Which professional and cultural factors have you experienced, whether recently or remotely? Just want to gauge where those sit with you. Please just choose one, single choice.
Got a couple more people to go.
All right. Just reviewing the chat responses as well. Okay. So psychological safety and hierarchy at the top of the list, and then fear of blame, liability, followed by role identity, and then interpretation of reportable events. So, and psychological safety and hierarchy is the leading factor that you all have experienced. And that's not unusual. Medicine still is driven by hierarchy, despite the many examples of high reliability industries. And VESH includes a manufacturing operations example where everybody had that stop the line authority, the Amdon core, as it used to be called early on. But yeah, lots of mention of fear of retaliation, fear of being saved, lack of support. So great engagement. Thank you all. So yeah, the psychological safety and hierarchy. We'll talk a little bit about what we can do about that when we get to solutioning. So next is system workflow and organizational barriers. So the system side of safety reporting. So we start with design of reporting systems. I haven't heard from anybody that they think they have a great reporting system unless they're the company that actually produces it and operates it. So whether you're using Midas, whether you're using RLDatix, whether you're using any other platform, everybody finds that they're clunky. And ultimately, the reason for that is this first point that systems are designed for back-end users rather than for reporters, right? The reporter is simply the gateway, if you will, the entry point, but it's the analytics in the back end of the system aggregating across multiple events that is really what the systems are designed for. So there's definitely room for improvement around the system design for the reporter on the front end. Additionally, we know that professional time and digital burdens impact the willingness to report. Nurses are at the bedside for multi-hour shifts, but are covering multiple patients. And so have a bajillion tasks in front of them. They have scheduled break times. Oftentimes it doesn't go to plan. They may get called away for off-unit activities related to a patient who's temporarily off unit, or they may have committee meetings to attend. So lots of time and digital burden for them. Physicians are constantly on the go, with the exception of intensive care units, emergency departments, the med surge units, all of the floor units of a hospital, for example, typically have physicians moving among many floors or many different units on the same floor. It's rare. We see it more in Europe and other parts of the world that physicians are assigned and dedicated to specific units. And so they're just caring for patients on that unit. It decreases the time spent moving. But with 15 or 20 patients that they're responsible for in a day versus 4 to 6 patients per nurse, there's a higher volume burden on physicians in terms of the number of patients they're caring for, spending a lot of time in digital documentation, ordering, review of information, et cetera. So those professions are facing lots of different time burdens and digital burdens, but of slightly different character. Feedback loops and learning systems are particularly weak in many reporting systems and many healthcare systems. And this gets to Jeanne's point that nurses do perceive more action from reports than physicians do. And in part, that comes from that different threshold for reporting. So nurses will tend to report more things into the system. Additionally, nursing reports get reviewed by nursing leaders. So there may be some feedback, at least on receiving the report and doing something with it. The key feedback, though, is what's quality, safety, and any performance improvement team doing with that information beyond just receiving it and acknowledging it. Is it actually resulting in change? But nurses tend to engage much more in quality and safety processes. Often, many physicians will perceive quality and safety as nursing domains, nursing responsibilities in terms of committee work and in terms of the staffing of quality and safety departments. So that may also contribute to nurses perceiving that there's more action from their reports. Nurses are reporting lower level, smaller issues, and it's easier to address and manage smaller issues. So it's easier to close it out and offer some feedback. When it's a massive structural or workflow process issue that affects multiple units and the entire facility, it takes a lot longer to get those changes in place. And that's the kind of thing a physician might be more likely to report. Nurses report them too. I'm not saying they don't, but in terms of the thresholds for reporting I was talking about, that's more of a physician threshold, those larger, more grandiose issues. And those take much longer to act on. And by the time they get acted on, oftentimes the source is relatively forgotten. So the feedback loop is pretty weak. So that speaks to some of the dynamics as to why nurses both report more, but also perceive more action from reports through that stronger and more frequent engagement with the reporting system and with quality and safety teams. Adding to that is because nurses are using that system more often, they don't perceive as much ambiguity in the event classifications. Whereas physicians don't engage nearly as much in the reporting system, in the committee work, even in adverse events. Oftentimes, sorry, not available, have to see patients. It's harder to garner full participation in physicians. And so they don't exist in that world of these definitions. So they're less clear on what's the difference between a good catch, a near miss, an adverse event. What are truly unsafe conditions? And the example I used before, if it's behavior and conduct, physicians may not perceive that at all as an unsafe condition, whereas nurses might realize and perceive that is very unsafe because if we can't communicate effectively, if I'm worried about giving you information that you're going to attribute to me and jump down my throat instead of perceiving as a safety risk and something we need to address collectively, then I'm less likely to tell you about it. And that jeopardizes the patient's well-being and safety. So ambiguity in our event classification, sometimes it's the terminology used in the systems as well. It's not clear enough, particularly when we start splitting the hairs, like with NHSN definitions, the National Hospital Safety Network definitions from CDC. That may not be plain language to make it understandable, or when we've got all these narrow windows and exceptions that are part of the definitions. Competing priorities and time pressure figure in to the workflows and system barriers, as well as the personal and cultural. So the driven productivity standards, whether a physician or a nurse, on patient volume, staffing ratios, the geographic range for physicians, as we talked about before, for nurses, if they're having to cover multiple different units, if they're floating, clinical workload, so the acuity of the patients that were being cared for, if that's not being factored into the staffing ratios. And in the independent work model, such as physicians who are credentialed and privileged in the hospital, but they're not hospitalists, they're not employed in the hospital. So they have their clinic offsite that they have to get back and forth to, and it has patients waiting. They have time blocked out for rounding, for procedures, but schedules don't always work out exactly. So that also creates these time and priority competitions for the work to get done. And then finally, organizational policies and incentives. So those are defined by this system. There are accreditation pressures, and typically we find that nursing across the board is much more in tune with accreditation standards and the accreditation process. Physicians still more distant and uninvolved with the process, not to mention then the ongoing constant pressures to maintain accreditation readiness. Leadership expectations are not physician or nurse driven. They're coming from the C-suite and from levels of leadership just below the C-suite. And then unit culture can additively influence nurse reporting in particular. So, there's nursing leadership and messaging and huddle simulation, for example, regarding safety event reporting, it's much more likely to happen across all of the nurses on that unit. It's a normalized behavior. On the other hand, if safety event reports are mentioned on huddle in a dismissive way or in a derogatory way, though another report that no one's going to do anything about, that's influencing everybody who hears that at huddle and increasing likelihood. So it's normalizing the deviance from the expectation to report. So another poll to gauge your experiences: which system workflow and organizational barriers have you experienced of the 5 that we just discussed? Give me a moment to answer that while I look at the chats. Okay, here's our results. Competing priorities and time pressures, number 1, experience, followed by reporting system usability and workflow. Those 2 really dwarf the others. And that's a very common experience. So that would seem to point us at needing to address hierarchies from before and needing to address the reporting system design and usability, as well as competing pressures, priorities and time pressures in our solutions. So let's start moving in that direction. And let's talk about finding some common ground for patient safety, because ultimately that's really what this is about, is not having conflicting perspectives between physicians and nurses that leave patients in the middle, holding the bag, so to speak, basically at risk. But instead, how we come together as a unified team, physicians, nurses, and all of the other allied health professions and support staff, to put the patient priority first and foremost and keep patients safe. And some of that has to do with giving up some status and ego. A lot of it has to do with changing how we think and communicate. But I want to plant this seed now, and we'll finish with this later, that we've spent a lot of time in the last 20 to 30 years in safety trying to change people's behaviors. And not just the bad behaviors, but changing behaviors in general, behaviors around hand hygiene, behaviors around sterile process, et cetera. Changing behaviors. We're not spending nearly enough time changing our system designs. And so we're going to keep tugging on that theme as we continue on from here. So this started with a conversation that Jeanne Huddleston and I had, and my knee-jerk reflex solution for this was, if safety event reporting systems are being weaponized, we just need to create a separate channel for reporting of conduct, behavioral issues, et cetera, that go to HR, go to the medical staff, but are separated out from safety. And I thought about how we make that happen. You can see it described here: developing a separate reporting system, training the workforce on the two separate systems, creating a report transfer process in case there's inappropriate reporting in one or the other, so it gets moved appropriately to the other platform, and managing medical staff reports through med staff administration. And there was something about it, it just wasn't quite sitting right with me after I really started thinking harder about it in terms of how effective it really would be, because essentially it's just moving a problem from one channel into another, but it's not changing the dynamics that actually lead to that problem, right? It's not addressing those differences in how physicians and nurses are perceiving risk and safety threat to patients. It doesn't change how we're educated, how we're trained. It doesn't change the hierarchy dynamics. So I started thinking, well, what are some other typical solutions? So first and foremost, and I think this would resonate with the majority who responded to reporting system workflow and design being optimal, is redesign the reporting system, make it easier to use, give it more relevance. Then we could think about strengthening psychological safety and just culture, right? Let's eliminate the blaming, the shaming. Let's focus on understanding, giving grace to human error, and coaching and teaching the at-risk behaviors, and reserving punishment, discipline, and ill judgment, if you will, for reckless or unacceptable risk, knowledge, or purpose to cause harm. We can create shared interprofessional learning structures. So let's learn together side by side, better understand each other, provide timely and role-specific feedback on reports. A physician giving feedback to a physician who reported a risk, or a nurse who gives feedback to a nurse who reports an event or a risk. We can clarify definitions and expectations for reporting. So let's make those definitions more clear, use plain language. Let's clarify the expectation to report. Let's define a threshold for everybody, allowing for these different thresholds. And let's think about incentives and recognition, using positive reinforcement for reporting of events. But as I thought through all of those, the first one is a system redesign change. But all of the other ones are about changing people, changing behaviors. So we know that's already not been very effective. So it doesn't seem like the best use of time and energy to keep beating that dying horse, so to speak. So then I started thinking about atypical solutions. And I thought, let's play with AI a little bit. And I queried AI to generate atypical solutions beyond these typical solutions. And here's what my synthesis of AI's responses looks like. So dual perspective reporting, meaning any report has to have the balanced report from another profession. If the nurse reports, then if there's any physician involvement, physician has to report. If it's pharmacist involvement, pharmacist has to report, et cetera. You do a safety round swap, so a temporary role immersion. So physicians, nurses, pharmacists, other allied health professionals rounding together for safety, but having to adopt another's persona. So if you're a pharmacist, you have to use a nursing lens or adopt a nursing persona. If you're a nurse, you have to adopt a physician's persona as a way to maybe try to better understand different perspectives. We could create psychological safety heat maps. So identifying which units have stronger psychological safety than others. And that can be based on things like our culture of safety surveys, whether you're using Press-Ganey, whether you're using HRQs, Hospital Survey of Patient Safety, ASOPs, as it's known. Next, there's safety story exchanges. We know the power of storytelling is really profound. It relies on anecdote, but if it's supported by evidence, it makes it stronger. Using narrative medicine techniques for safety story exchanges can be really helpful. Micro reporting via voice or wearable devices, meaning instead of a reporting system that has 20, 30, or 40 fields of data that have to be filled in, what if a reporting system only had 5 or 6 data fields? Time, date, location, patient identifier, and then a simple lay statement about what happened. And then all the rest follows as part of the learning process from that. And there are some companies that are experimenting with those kind of micro reporting systems. Shared safety vision contracts. So physicians and nurses together co-create this vision of what safety looks like on these units or for specific types of patients. And then the final atypical solution, reverse feedback loops. So reporters choose the feedback format. Do they want a phone call? Do they want a text message? Do they want to know along multiple steps of the process, or do they just want to hear at the very end when everything is figured out and action plans are in place? I thought about those, and again, it looked like one or two of those, like micro reporting and system design around the reporting technology or system design. But again, most of it was about people, about changing people, how we perceive each other, how we think, walking in someone else's shoes, appreciating their others' perspectives. But the thing that really landed for me when I thought about the dual perspective reporting, having a physician and a nurse both reporting, I had my light bulb moment where I remembered safety learning system, Jeanne's one. And as I thought more about that, and it's very structured record review process, but not from events that have happened, but from cohorted patients of interest where risk may be present, where safety risks, safety process problems, issues of care, opportunities for improvement may exist, and we're not even addressing, we may not even know it. We look through the lens of a physician and a nurse. And we don't say one is right or wrong. We say both matter. They're looking through different lenses. If either one finds anything, it counts and it goes in the database. Yeah, dual professional review. Shifting from reporting to learning. So instead of only taking action to learn about our system design when things have gone wrong, like we do with safety event reporting, what if we instead were learning about where our vulnerabilities lie, where we have risks that we don't even see because it doesn't show up? And a point that Jeanne shared with me in our conversations is, what do we do with all of the risks and the types of safety events that don't fall into our standard nomenclature? What if it's not a healthcare associated infection or a healthcare associated condition? What about all the other stuff? And that's what safety learning system is finding in abundance. So learning about vulnerabilities in our system so we can improve them rather than waiting for bad things to happen and then trying to improve the system so it can't happen again. Focusing on the system contributors, right? The little things instead of the big thing. Don't wait for it to blow up on you. But thinking about all the various contributors that can snowball or that represent the different slices of Swiss cheese and the holes in the cheese, rather than just looking at individual error, at one person's performance. And I'll editorialize a little bit to say, I really don't like using the word error because it gets misused so much when we talk about physician error, diagnostic error, safety errors, human error. Error truly, according to James Reason, means inadvertent actions. And a lot of what we call error is not inadvertent, but it's a wrong choice. It's a misperception of safety risk, or it's a system that isn't designed to capture and isolate a risk before it can reach a patient. And we call all of that error. Individual actions is probably a better term than error, because we really want to be able to give grace to human fallibility. Also in safety learning system, the rapid structured learning loops. So the ability to quickly translate findings in the data to actions. And that comes from the review and prioritization at the interprofessional multidisciplinary committee. So bringing that aggregated data from these reviews completed by physicians and nurses, and dropping a teaser here in the future, if that feels like a lot of manual workload, maybe some AI augmentation even through that persona, that lens of a physician persona, a nursing persona, but bringing that data, whether it's from people or whether it's AI augmented, to a people committee of nurse and physician, multiple specialties, who then realized they share the same problems they had no idea anybody else was dealing with, and can then prioritize that for the system of care and address problems before they actually result in harm at all. And then finally, as I mentioned earlier, gratitude spans the boundary between professions in safety learning system. So both looking for the expressions and the acknowledgement of gratitude for work well done, for excellent care provided, for detecting something awry before it turned into a bigger problem, and being public and transparent and documenting that in the medical record, right? That's the only way to find it in SLS, is to see it in the record. And that's really powerful. We worry about all the things that might be damning or incriminating in legal proceedings. But if there is gratitude and expression of competence and excellence in the medical record, that's pretty amazing. So as I then thought about safety learning system in the context of these atypical solutions, wow, you checked a lot of boxes, right? SLS definitely covers the dual perspective reporting, covers the safety round swap. It supports psychological safety heat mapping. It addresses safety story exchanges, which is what happens in the committee meetings. But the only one it doesn't really address is micro reporting. The micro reporting only validates you plan to continue reporting after the fact rather than learning ahead of time. And you can see the other check marks as well, where safety learning system addresses all these components that represent atypical solutions. So one more poll for you. Typical and atypical solutions. Which solutions might you pursue now, having heard all of this information? A separate conduct reporting system, a human behavioral adaptation, an adverse event reporting system upgrade, or replacing your adverse event reporting system with safety learning system. And you can check more than one. Sorry, single choice, my bad. Single choice configured poll. I'll take another moment to look at the chats. Thank you all. I appreciate the continued conversation in the chats. As you mentioned, of just culture and a combination of solutions that are in process. Excellent. I'm sorry, I was looking at the chats. I didn't get to see the results. Could you put the results back up for just a moment, Allison? Wonderful. Thank you. So number one, replacing adverse event reporting system with safety learning system for half of you. That's impressive. I'm excited by that. And human behavioral adaptation, second to that, 40%. And I would just, again, caution, there's only so far we can get with human behavioral adaptation in terms of trying to affect culture, trying to change how people think. We can change systems that will influence those things, like just culture, for example. But just culture has to be implemented within the system as a system component so that it's consistently applied to any and all lapses of expectations across the board if we want to see it change behaviors. If we don't do it that way, behaviors don't change. Thank you all for your responses on that. All right. Final topic before we wrap up, navigating change to address barriers. Remember, I told you I'll present you some solutions, but then we'll also talk about some advice and recommendations for how you can be more effective in implementing for longer term stickiness and sustainability. We'll start with a change management model called the ProSci ADKAR model. This is a sequential process of creating awareness and then motivation or desire before you start any education or training, and then flipping the switch on, activating ability, as well as then having in mind from the very beginning as we plan these steps, the reinforcement or sustainment to keep the process going long after the fact. I won't go into each and every element here because I know we're getting short on time, but starting with the ADKAR model, I have found that additionally, the ITI psychology of change framework in addressing behavioral aspects of leading change and being part of change is incredibly helpful, from unleashing intrinsic motivation, finding those frontline leaders who really want to step in and be part of creative change, co-designing people-driven change and co-producing in authentic relationships, distributing power, meaning reducing those authority gradients, reducing hierarchies, and giving more people involved in the process decision-making power and implementation authority, and adapting in action. So learning actively throughout the process of implementation and change, and adapting to the circumstance and adapting to the people. This one I think is really worth some focus for a moment, because we think a lot about how we're going to help to be part of a change, how we're going to lead that change, how we're going to sequence it, how we're going to communicate about it, get people interested. The Bridges transition model focuses instead on being the recipient of change. And when change is put upon us that we aren't enthused with, we see the drop off in performance, and we go through these stages almost like grieving before we see performance improve. And the goal is we not only want to see performance come back to baseline, we actually want to see it go above baseline because that's the purpose of the change in the first place. And this ties back to Peter Senge's quote from years back that people don't mind changing, people mind being changed. So this is the process though that people go through when they're being changed. And it's not to say it's impossible, but we need to be cognizant of these changes in performance and the stages people are going through as being on the receiving end of change as we manage that change from the role of leadership, leading that change. So it's a complementary balance to the sequence and psychological process. Now, the other thing to keep in mind is the Rogers diffusion of innovations model. Everett Rogers defined this years back about this curve of willingness and timescale of change. So on the left-hand side, the tail of the bell curve is the innovators, the first people to adopt change. You can think of time running across the horizontal axis below those titles and percentages. So the innovators jump on board early. They're willing to take the risk. There's only a few of them. And then we move into the early adopters who are quick to follow innovators, want to be on that leading edge, but maybe a little more risk averse. And then you get this chasm, right? This gap in time before the early majority says, hey, that makes good sense. I think there's evidence base that supports it, or our gut says that's the right thing to do because enough people have done it successfully. So let's start getting on board with it. And then you get into the late majority, right? People want to see a lot of evidence, a lot of effectiveness. They really like the way they already work. They don't want it to change. Maybe they're deep in that Bridges model. They're the most change resistant because they feel like it's being done to them. And then finally on the tail, on the right-hand side, a much larger proportion than the innovators, you see the laggards, those who drag their feet, who may even actively sabotage efforts to change. And an important takeaway from this is don't waste your time on the laggards, right? They're only 16%. And as long as they're not being vocal and sabotaging, they're just dragging their feet. They'll either come along eventually or they'll get off the bus. Don't spend your time on them. If they're being vocal, if they're being disruptive and they're affecting your early and late majority, then you may have to do something actively to quell their dissent. You might think about putting them in charge of part of the change because sometimes that can be particularly effective in changing their perspective, bringing them up out of their depths of the Bridges model and taking a very active role, becoming a supporter instead of being laggard. And then finally, quality as an organizational strategy, which maps out how to align your improvement efforts back to your organizational purpose and the system view, the map of your organization, how it operates. And so the parting thought here is that integrating these models can increase the impact. Don't just use one of them in isolation. Think about how you can combine two or more of them. I found ADKAR coupled with psychology of change works incredibly well. The Bridges transition model coupled with Rogers innovation to really understand where people are at and what the timeline's going to look like is super helpful. So I wanted to leave that as a parting solution. So to wrap up today, thinking about real solutions to the issues of these two conversations and the different perceptions of the one word safety. One option is to create these separate channels for reporting safety versus conduct. It's low hanging fruit, enables quickly moving out of the weaponization of safety reporting, but it doesn't absolutely solve the problem, right? You're still dealing with the hierarchies and the differences in perceptions, the thresholds, et cetera. Second would be redesign the system of safety reporting with a focus on detecting. Accreditation and regulatory organizations may be requiring safety event reporting systems and reactive postures, but that doesn't mean you can't start moving forward with something like safety learning system, getting more proactive and identifying the opportunities before they even rear their heads as harm events. And then finally, testing and actively managing the change. The testing part comes in that quality as a business strategy or as a operational strategy, testing different modes of implementation, testing some different tools, maybe testing some of the different typical or atypical solutions. If it's implementing safety learning system, might be testing the implementation of different phases of safety learning system operations. But you can test your way into it. It doesn't have to be a leap of faith. It doesn't have to be jumping into both feet, all or nothing. It can be sequential, it can be learning based, much of the psychology of change informs us so that you get maximum benefit, maximum effect from your efforts. And so with that, I'll leave you with this parting thought that patients are safer when professional perspectives are shared and aligned. Let's change the system, not the people. Thank you very much.
Thank you so much. I've got a ton of questions for you and more conversation I think we'll probably have over the coming weeks. I want to honor everyone's time and thank you so much for staying with us. As usual, in about a week, we will have this reproduced and put out in our learning management system. Please share that link with as many people as you can. I think this is really important work to start thinking about the differences in how we perceive things and that it's natural and it's normal and we can translate. Thank you, everyone. Have a great rest of your week.
Thanks all.